Welcome to the deep dive. Today, we're really tackling a big one. Equine small intestinal obstruction. You'll often hear it called SIO.
Hmm.
It can be incredibly complex and sadly often life-threatening for horses.
It really can.
We've got a pretty hefty stack of veterinary sources here, really comprehensive stuff. And our mission, as always, is to dig through it all, pull out those key nuggets of knowledge, the really important bits, and give you a shortcut to being properly informed about this critical issue.
Absolutely. And, understanding SIO isn't just for vets. It's crucial for anyone who owns or works with horses.
Right.
Because while colic is the general term we use for bellyache, SIO is a very specific and often very severe type of colic. And the really critical thing, for some types, the time frame you have to act, well, it can be incredibly, incredibly short. So recognizing it early and acting fast is just paramount.
Okay, let's unpack this then. To really get a handle on SIO, where do we start? What exactly is it?
So at its most basic level, SIO means that the normal movement of food material, we call it ingesta, is impaired.
Right, the food can't move through.
Exactly. It gets blocked somewhere in the small intestine between the stomach and the cecum. Think of it like a major traffic jam inside the horse's gut.
Got it, a traffic jam.
But here's where it gets really important. We need to distinguish between two main types.
Okay.
First, you have non-strangulating obstructions, or NSOs. These are physical blockages, maybe impacted feed, or something else stopping the flow. But crucially, the blood supply isn't cut off to the gut wall itself. These are actually, well, they're more common. They make up maybe 80% or more of colic cases that show up.
Okay, so more common, but the blood's still flowing.
Right. But then you have strangulating obstructions, SOZOs. And this is where things get really critical really fast.
Oh.
Here, a piece of the intestine actually twists on itself or gets trapped somewhere it shouldn't be. And the key point is this cuts off the blood supply, completely interrupts it.
Oh, wow.
This lack of blood flow, the vascular compromise, causes the tissue to start dying very, very quickly. And that absolutely requires immediate surgery.
So that distinction, NSO versus SO, it's not just technical, is it?
Not at all. It dictates everything. The urgency, the type of treatment. It's
Yeah.
often, quite literally, the difference between life and death.
That really highlights why horses seem so prone to this. Their anatomy plays a big role, doesn't it?
It absolutely does. Take the jejunum, that's a big part of the small intestine. It's incredibly long.
How long are we talking?
Around 65 feet, maybe 19, 20 meters. Just imagine that.
Wow.
And it hangs in the abdomen, suspended by this sort of fan-like membrane called the mesentery, which is also really long and mobile.
So it can move around a lot.
Exactly. Which is great for digestion usually, but it also makes it really susceptible to twisting. We call that volvulus, or getting trapped, incarcerated.
And there are specific spots where it can get trapped.
Yes. There are natural openings inside the horse's abdomen, like the inguinal canal, especially in stallions or geldings, and a space called the epiploic foramen. These can, unfortunately, become sites where a loop of intestine can slip in and get stuck.
Okay, so the anatomy definitely sets them up for potential problems. What happens then pathologically when there's an obstruction?
Well, whatever the cause, strangulating or not, the first thing that happens is the intestine starts to distend. It fills up with gas, fluid, and the ingesta that can't move forward.
Now that hurts.
Oh, absolutely. That stretching activates pain receptors in the gut wall. And that's what causes the signs of colic. We see the pawing, the rolling, flank watching.
Right. But the strangulating ones sound much worse systemically.
They are. Because when that blood supply is cut off, ischemia, we call it the tissue, starts dying almost immediately. Necrosis. And the sources we looked at, they paint a pretty stark picture. The intestinal lining, the mucosa, which is super metabolically active. It has these tiny finger-like villi. They can be completely stripped away, denuded in just 3 hours of ischemia.
3 hours? That's incredibly fast.
It is. And the deeper parts, the crypts that are needed to regrow that lining, they're lost by maybe 4 or 5 hours. That tiny window is just such a critical takeaway here. Time is everything.
And what about the rest of the horse's body?
Huge systemic effects. Massive amounts of fluid get pulled into the blocked gut, basically taken out of circulation. This leads to severe dehydration and hypovolemic shock.
Okay.
Plus, as the gut wall breaks down, dangerous bacterial toxins, endotoxins, leak into the bloodstream. That causes endotoxemia.
Is that the toxic line people talk about?
Exactly. That dark red or purple line you might see along the gums, that's a visible sign of endotoxemia and shock. And one more really crucial point, especially for small intestinal issues, gastric reflux.
Because horses can't vomit.
Precisely. Since they can't vomit, if the small intestine is blocked, fluid and ingesta back all the way up into the stomach, If that pressure isn't relieved by passing a nasogastric tube, tubing the horse, the stomach can actually rupture, which is catastrophic.
Just devastating. Okay, so we understand the what and the how. Now, the big question for horse owners, why does this happen? And are certain horses more at risk?
That's key, isn't it? Understanding the why and who is vital for prevention where possible, and definitely for catching it early.
So what are some specific types and their risk factors?
All right, let's break a few down. First, ileal impaction. This is a blockage in the very last part of the small intestine, the ileum. It's quite common in the southeastern U.S., and there's a really strong link. The sources are clear on this with feeding coastal Bermuda grass hay.
Coastal Bermuda. Okay, good to know. Any other factors?
Yep. Tapeworm infections, specifically Anoplocephala perfoliata, can be involved. Also, poor teeth, meaning they can't chew the hay properly, any sudden diet changes, and just not drinking enough water.
Makes sense. What's next?
Ascarid impaction. This one's pretty specific.
Yeah.
You see it almost exclusively in young horses, weanlings, usually around 5 months old.
Foals. Okay.
Yeah, foals with really heavy burdens of roundworms parascarsoquorum. And what's really fascinating and kind of counterintuitive, the colic often happens right after you deworm a heavily infected foal.
After deworming. Why?
Because the sheer mass of dying worms tries to pass through the small intestine all at once, and it can physically block it up. A tragic irony, really.
Wow. Okay. That's definitely one to be aware of with youngsters. What about older horses?
Good question. That brings us to strangulating lipoma. Lipomas are these benign, fatty tumors.
Fatty lumps.
Exactly. They tend to grow on the mesentery, that membrane holding the intestine. Over time, they can develop a long stalk, like a pendulum. And that stalk can wrap around a loop of intestine and literally strangle it, cutting off the blood supply.
That sounds awful. Who gets those?
It's most common in older geldings. The average age is often around 19, usually over 15 years old.
Any breed predisposition?
Yes, some breeds seem more prone. Arabians, Morgans, saddlebreds, quarter horses, even ponies. And there's often a link to the horse being, a bit overweight, maybe showing signs of obesity or insulin resistance.
Okay. Older, potentially overweight geldings. What else causes strangulation?
Another big one is epiploic foramen entrapment, or EFE. Remember that natural ovish we mentioned, the epiploic foramen?
Yeah. Yeah, near the liver, right?
That's the one. A loop of small intestine can slip through that opening and get trapped, strangulated.
And are there risk factors for that specifically? This is where it gets really interesting.
It really does. The data shows an incredibly strong link, like an odds ratio of over 67, which is huge, between EFE and certain behaviors.
Which behaviors?
Crib biting and wind sucking.
Seriously.
Cribbing.
Seriously. It strongly suggests these behaviors, often called stereotypies or vices, aren't just, annoying habits. They might be indicators of underlying stress or maybe even changes in abdominal pressure that actually predispose these horses to this specific, very severe type of colic.
That's fascinating. Changes how you think about those behaviors.
It really does. Also, taller horses, thoroughbreds, warm bloods seem to be at higher risk for EFE as well.
Okay, one more type you mentioned.
Right, intussusception. This is where one part of the intestine basically telescopes inside the section next to it.
Like turning a sock partly inside out.
Exactly like that. It causes both a blockage and often compromises the blood supply too. And who gets this?
This one tends to affect younger horses more often, say from 6 months up to maybe 3 years old.
What triggers it?
Often things that cause abnormal gut motility or irritation, like inflammation, maybe enteritis, rapid diet changes again, or sometimes parasitic infections can set it off.
So looking across all these different types, you definitely see some common themes emerging, don't you?
You really do.
Sudden changes in diet pop up repeatedly, parasite burdens, both tapeworms and ascarids.
Yeah.
And anything that messes with normal gut motility, whether it's inflammation or maybe even stress, leading to behaviors like cribbing.
Exactly. It underscores that consistent, careful management is so important.
Yeah, it really brings it home. Things like sticking to a stable, mostly forage-based diet, making any changes super gradually.
Over 10 to 14 days, ideally.
Right, having a really good targeted parasite control plan based on fecal tests.
Crucial, especially for those foals and ascarid.
Making sure they always have clean water, getting their teeth checked regularly.
Every 6 to 12 months. Proper chewing is the first step of digestion.
It seems like getting those basics right consistently can really help reduce the risk for a lot of these SIO problems, even if you can't eliminate it completely.
That's absolutely the foundation. Good management is key for prevention. But, SIO can still happen even in well-managed horses.
True.
And when it does, getting an accurate diagnosis and getting it fast becomes the absolute priority.
So how do vets figure out what's going on? It sounds complex.
It often is. It's usually not just one test. It's like putting together pieces of a puzzle, combining the horse's clinical signs, what you find on examination, with more advanced stuff like imaging and lab work.
Okay, so starting with the basics, what signs might you see that scream small intestine problem?
Well, you'll likely see the general signs of colic pain, the flank watching, pawing, maybe trying to lie down or roll. Often the pain can be quite severe with SIO.
And heart rate, gut sounds.
Heart rate is usually elevated, often significantly, and gut sounds are typically reduced or totally absent, especially over the small intestine area. But here's maybe the biggest clinical clue, the real hallmark for small intestinal issues.
The reflux.
Exactly. Getting significant amounts of gastric reflux when you pass that nasogastric tube, that's a major indicator that the blockage is upstream in the small intestine compared to most large intestinal colics where you typically don't get much reflux.
That makes sense. And what about those systemic signs we talked about?
Yeah, you'll assess for those too. Signs of dehydration like tacky gums, skin tinting. Check the gum color. Are they nice and pink or are they becoming dark red, maybe showing that toxic line? That, along with a really high heart rate, points towards shock and endotoxemia.
Okay, so clinical exam gives you strong suspicions. What are the next steps? The advanced tools.
This is where abdominal ultrasound becomes incredibly valuable. It's a fantastic tool for looking inside.
What can you see on ultrasound?
Key things you look for are distended loops of small intestine. Normally, you don't see much fluid-filled small intestine on ultrasound in a healthy horse.
Ah, all right.
But with an obstruction, you'll see these loops fill up with fluid, looking much bigger than normal diameters, can range quite a bit, but definitely enlarged.
What about the gut wall itself?
You look at the thickness. A thickened intestinal wall is another sign of trouble, maybe inflammation or edema due to lack of blood flow. Normally it's very thin, maybe 3 millimeters or less, but in colic cases, especially strangulating ones, it can get much thicker.
And motility, can you see if it's moving?
Yes, and that's critical. One of the most specific findings for a strangulating obstruction on ultrasound is seeing these distended loops just sitting there with a complete lack of motility. They're not contracting or moving fluid along. Some studies report that finding has like 100% specificity for strangulation.
Wow, that's definitive.
Almost. And sometimes, with intussusception, the telescoping gut, you can see a very specific image on ultrasound called the target sign. Looks just like a bullseye. If you see that, it's basically diagnostic for intussusception.
Okay, ultrasound sounds powerful. What about analyzing fluid from the abdomen? Abdominocentesis.
Yep, belly tap. Pulling a sample of the peritoneal fluid, the fluid that normally lubricates the abdominal organs, can give you absolutely vital clues.
What are you looking for in the fluid?
First, just the appearance. Normal fluid is clear, maybe pale yellow, and watery.
Okay.
If the fluid comes out looking reddish or brownish, bloody and watery, we call that serosanguineous. That's a strong indicator of damage to the bowel wall, maybe bleeding, almost certainly strangulation.
The color tells you a lot. What else?
You analyze the cells and protein. High white blood cell counts in the fluid suggest inflammation. High protein levels suggest leakage from damaged blood vessels or intestine. Both point towards serious trouble.
And you mentioned lactate before in the context of ischemia.
Yes, this is a really important one. You can measure lactate levels in both the blood and the peritoneal fluid.
And compare them.
Exactly. If the lactate concentration in the peritoneal fluid is significantly higher than the lactate measured in the blood at the same time, that's a very strong indicator of intestinal strangulation and ischemia. The damaged gut is basically dumping lactate into the abdominal fluid.
So abdominal fluid lactate higher than blood lactate points to strangulation.
Precisely. Often the peritoneal lactate might be over 7 millimole, while the blood lactate might still be relatively normal, say under 3 in non-strangulating cases, or lower than the belly tap in strangulating ones.
Okay. And what about just regular blood work?
Blood work helps assess the horse's overall status, hydration, electrolytes, kidney function, inflammation. But for specifically diagnosing ischemia or predicting surgical need, blood L-lactate itself is considered probably the most reliable single blood marker right now. High blood lactate suggests poor tissue perfusion overall, often linked to strangulation and shock.
Any other useful blood markers?
Serum amyloid A, or SAA, is gaining traction. It's an acute phase protein, a marker of inflammation. Elevated SAA can be really helpful in differentiating horses that likely need surgery from those that might respond to medical management. It adds another piece to the puzzle.
It really sounds like you need to piece all these clues together. The clinical signs, the reflux, the ultrasound, the belly tap, the blood work.
You absolutely do, and quickly.
Because the damage is happening so fast, right?
Yeah.
Those markers, especially for ischemia, they change rapidly.
Exactly. That's why getting a vet involved early, and if necessary, referring the horse to a surgical facility without delay is absolutely critical. Catching those indicators early makes a huge difference to the potential outcome. You're truly racing against the clock with strangulating lesions.
Okay, so diagnosis is made, or strongly suspected. What are the treatment paths? You mentioned medical versus surgical.
Right. The path depends heavily on the suspected cause. Is it likely strangulating or non-strangulating? And how sick is the horse? Medical management is the primary approach for many non-strangulating obstructions, like maybe a simple ileal impaction, or it's used initially to stabilize a really critical horse before potential surgery.
What are the goals of medical management?
Several key things. Relieve pain, correct the dehydration and electrolyte problems with IV fluids, try to counteract the effects of endotoxemia if it's present, and manage gut motility.
And the nasogastric tube is vital here.
Absolutely life-saving. That nasogastric decompression, regularly passing the tube to remove the reflux, prevents the stomach from rupturing. You often have to tube these horses repeatedly every couple of hours sometimes.
What about pain relief?
Essential. We use NSAIDs, like flunixin, meglumine, banamine is a common trade name. Also, alpha-2 agonists, like xylazine or ditomidine, which are potent sedatives and pain relievers.
But you mentioned caution with those.
Yeah, the alpha-2s can unfortunately also decrease gut motility, which you don't really want long-term in an obstruction case, so it's a balance. Opioids like butorphanol are also used, and post-operatively, or sometimes even medically, a constant rate infusion, a CRI, like a continuous IV drip of lidocaine, can be really helpful. It provides pain relief and might help encourage the gut to start moving again. It has prokinetic properties.
And fluids, you mentioned fluids are critical.
Hugely critical. These horses can sequester enormous volumes of fluid in their gut, so aggressive IV fluid therapy is absolutely essential to combat shock and dehydration. We're talking many, many liters of fluids.
Okay, so that's medical. When is surgery the answer?
Surgical management is the definitive treatment for any suspected or confirmed strangulating lesion. Time is of the essence there.
No waiting around if you suspect strangulation.
Absolutely not. Surgery is also needed for non-strangulating obstructions, like impactions, if they just aren't responding to medical therapy after a reasonable period.
What happens in surgery?
The surgeon explores the abdomen to find the problem. If it's a strangulating lesion, they'll try to correct the twist or release the entrapment. Then they have to assess the viability of the affected intestine. If it's damaged beyond repair due to lack of blood flow, that section needs to be removed. That's called resection.
And then you join the healthy ends back together.
Exactly. That's called anastomosis. Sometimes, for certain conditions, newer minimally invasive surgical techniques like laparoscopy can be used, which might mean smaller incisions and potentially faster recovery.
You mentioned the timing for surgery is critical for strangulating cases. What does the prognosis look like based on time?
It's stark. The sources consistently show that survival rates for strangulating SIO drop off dramatically after about 12 hours from the onset of signs.
12 hours.
But if you can get to surgery within, say, 6 hours of the strangulation occurring, the prognosis is generally much more favorable. Early intervention is everything.
That really hammers home the urgency. And after a successful surgery, recovery isn't straightforward either, is it?
No, the postoperative period is just as critical as the surgery itself. There's intensive monitoring needed.
What are the main complications you worry about after surgery?
Several big ones. Postoperative malaise is common. That's where the gut just remains sluggish or stops moving even after the physical obstruction is fixed. It requires continued medical support, fluids, sometimes pro-motility drugs.
Okay, ileus. What else?
Adhesions can form basically internal scar tissue that can potentially cause problems later on. And of course, managing residual endotoxemia and preventing infection are major focuses.
And getting them back to normal activity.
That needs to be gradual. A structured rehabilitation plan is vital. Usually, it involves strict stall rest initially, then gradually increasing turnout and controlled exercise over about 60 to 90 days, maybe longer, depending on the surgery and the horse. It's a long road back sometimes.
It sounds like a huge undertaking from diagnosis through recovery. Which brings us back to prevention.
Yes, always better if we can avoid it in the first place, right?
Definitely. So recapping those prevention strategies based on the risk factors we discussed.
Absolutely. Well, you can't prevent every case. Good management significantly reduces the odds. Dietary and water management is huge. A diet based mostly on forage. Any changes to hay or grain must be gradual. Think 10 to 14 days for a full transition.
So changes.
Crucial. And constant access to clean, fresh water. Dehydration is a risk factor for impactions. If sand ingestion is a risk in your area, using raised feeders or mats can help.
Makes sense. Parasites.
Parasite control. Not just indiscriminate deworming, but a strategic program based on fecal egg counts to target the specific parasites present. And critically, managing ascarids and foals before weaning and being cautious about deworming heavily infected ones, maybe using a slower kill dewormer initially.
Good point about the ascarids. What about general health?
Routine health care. Regular dental checkups, as we said, every 6-12 months, ensure they can chew properly. And addressing those stereotypic behaviors like crib biting or wind sucking. While we might not fully stop them, environmental enrichment, optimizing their feeding schedule, maybe more frequent forage meals, might help reduce the underlying stress that could contribute to conditions like EFE.
It's all connected, isn't it? The behavior, the gut health, the environment.
Absolutely. It's a holistic picture.
And are there any sort of new frontiers in tackling SIO? You hear about technology?
Yeah, there's some exciting stuff happening. Wearable tech things like the Night Watch halter or EquiSense systems that monitor the horse's vital signs and behaviors 24/7. They aim to detect early signs of colic, potentially even before humans notice.
So earlier alerts.
Potentially, yes. AI is also being explored for diagnostics, helping interpret ultrasound images or predict surgical risk based on clinical data.
Interesting. Any new therapies?
Research is ongoing. Things like cannabinoids for pain management are being looked at. And regenerative medicine approaches, could they potentially help heal damaged gut tissue faster? It's still early days for some of these, but the field is definitely advancing.
That's hopeful. Well, this has been a really comprehensive deep dive. We've covered so much from the horse's own anatomy, making them prone to SIO.
That long, mobile jejunum.
Right. To that absolutely critical difference between strangulating and non-strangulating blockages and how that dictates urgency.
Life or death difference sometimes.
And the precision of the diagnostic tools now, the ultrasound, the fluid analysis, the biomarkers. It's pretty amazing how vets piece it all together.
It truly is. Modern equine medicine has come a long way.
It really has.
This whole discussion on SIO, it just really highlights how incredibly interconnected everything is inside a horse. How their anatomy, their physiology, even their behavior, it all links together. And it shows how rapidly something that might seem like a simple tummy ache can escalate into a genuine life-threatening emergency. It really makes you wonder, doesn't it? It raises that question.
What's that?
What other subtle signs might our animals be showing us? Indicators of potentially serious issues happening beneath the surface, just waiting for us to connect the dots and understand what they mean before it's too late.
That is a really powerful thought to end on. Something for all of us involved with animals to keep in mind. Well, thank you for joining us on this deep dive. We hope you found it informative. Keep learning, ask questions, and stay well informed.